Assalamu alaikum. Now I would like to discuss on pheochromocytoma. It's a very high yield topic. In pheochromocytoma, there is a classical triad: episodic headache, sweating, tachycardia. Episodic headache, sweating, tachycardia. Sometimes this episodic headache may be absent and may come in the form of other scenario. Okay, but the classic point in here you have to remember, like in pheochromocytoma patient, when you suspect a patient with pheochromo, if you give three types of antihypertensive, three types of antihypertensive along with uh, three types of antihypertensive along with what? A diuretics. So in that three type of antihypertensive, there is a diuretics. Even if you give these drugs, but uh, it does not able to control his hypertension. So this is resistant hypertension or hypertension accompanied by unexplained increased glucose. So hypertension accompanied by unexplained increased glucose, this is very high. Accompanied by unexplained increased glucose, and there may be familial history and familial some syndrome men too, and neurofibromatosis men too, like men 2A and B, like men 2A is parathyroid, thyroid, and pheochromocytoma, and 2B is thyroid, pheochromocytoma, and neuroma, mucosal neuroma. There may be neurofibromatosis type 1 and VHL, von Hippel-Lindau syndrome. In von Hippel-Lindau, there is a mnemonic called HARP: hemangioblastoma, angiomatosis, renal cell carcinoma, and pheochromocytoma. In von Hippel, there is chromosome number 3p gene is abnormal. So chromosome 3p, von Hippel-Lindau, HARP. You need to remember diagnostic approach: urine or plasma metanephrine level, urine or plasma metanephrine, and confirmatory abdominal imaging with increased metanephrine, abdominal imaging with increased metanephrine. Notable features: 10% bilateral, 10% extraadrenal, and 10% malignant. 10% bilateral, 10% extraadrenal, and 10% malignant. Management is preoperative alpha blocker prior to give beta blocker. So you have to give alpha first, then beta, like phenoxybenzamine, then the propanolol. And laparoscopic or open surgical resection. So diagnostic approach: urine or plasma metanephrine level, and confirmatory abdominal imaging with increased metanephrine level. So high index suspicion of pheochromocytoma, there may be episodic headache and on and off hypertension, episodic headache, on and off hypertension. And there are some stems where you will see that the hypertension, like some people measure BP in his or her home and they are getting abnormal result, like today you get 120/80, the next day you get 160/90, then the next day you get 170/100, and then again you give 110/70. So these abnormal BP ups and downs. Think about pheochromocytoma. The high suspicion of pheochromocytoma: 24-hour urine unfractionized metanephrine, 24-hour urine fractionized, 24-hour urine fractionized metanephrine and catecholamine, 24-hour urine fractionized metanephrine and catecholamine, and plasma fractioned metanephrine. If it is normal, recheck during spell. Recheck during spell. If it is high 2 or 3 times in the upper limits of the normal. Do CT scan or MRI of the abdomen. Do CT scan or MRI of the abdomen, because it is a tumor of the adrenal medulla, so you have to do CT scan or MRI of the brain. If it is negative, consider further imaging like MIBG scan, meta iodo meta iodobenzyl guanidine, meta iodobenzyl guanidine scan, MIBG scan, octreotide scan, whole body MRI, and PET scan. These are the modalities you can take. And if CT or MRI of the abdomen is positive, surgical evaluation, genetic testing, alpha and beta blocker prior to the surgery, and MIBG scan. If tumor is more than 5 centimeter and suspicion of extra-adrenal disease, if you suspect extra-adrenal disease, then you should do MIBG scan. Okay, what are the surgical complication may happen? Uh, Surgical complication of the adrenalectomy for pheochromocytoma. Surgical complication of the adrenalectomy for pheochromocytoma. There may be hypertensive crisis, there may be hypotension, hypoglycemia, hypertensive crisis, hypotension, hypoglycemia, and cardiac tachyarrhythmia. Hypertensive crisis. There is increased catecholamine release due to endotracheal intubation, due to endotracheal intubation and adrenal gland manipulation, and increased serum norepinephrine with large tumor more than 4 centimeter in diameter. Increased serum norepinephrine with large tumor. In these cases, in hypertensive crisis, you should give IV nitroprusside, phentolamine, and nicardipine. IV nitroprusside, phentolamine, and nicardipine. Yeah, there may be hypotension. Decreased catecholamine after tumor removal. Decreased catecholamine after tumor removal. Increased catecholamine released due to endotracheal intubation and adrenal gland manipulation, and after the tumor removal there may be hypotension, so in there you should give normal saline bolus if unresponsive. Persistent alpha blockade preoperative and long acting alpha blocker like phenoxybenzamine should be given, followed by propanolol. And hypoglycemia may happen. Increase insulin secretion from the tumor removal. Catecholamine actually suppresses insulin secretion as the tumor is removed, so there is increased insulin secretion, and which uh, which will cause hypoglycemia, IV dextrose infusion, and cardiac tachyarrhythmia. Increased catecholamine release from adrenal gland handling, IV lidocaine, and esmolol. So these are the complications can happen. Hypertensive crisis due to increased catecholamine, hypotension due to decreased catecholamine after the surgery, hypoglycemia due to increased insulin secretion, as the catecholamine suppresses the insulin secretion. So no catecholamine, more and more insulin, and cardiac tachyarrhythmia, increased catecholamine release from the adrenal gland handling. So this is all about pheochromocytoma. It's a wonderful disease of diagnosis. Hope you enjoyed. And at last I will show my intro where you will hear a heart sound. Can you tell me the name of this heart sound? Okay, if you know, then put it in the comment box. Hope you enjoyed.